Okay, I hope you all enjoyed those talks as much as I did. Whether the glass is half full or half empty in this field entirely depends on your perspective. The half full version is drugs for neglected tropical diseases. The word neglected is a great deal less appropriate now than it was 10 years ago, which is great. Where I would urge caution is the glass half empty approach, which is that a lot of us in this field do tend to compare ourselves with what's happening in malaria and TB. It's a very salutary lesson if you then go and compare what's happening in our field with, for example, neurodegenerative diseases, including Alzheimer's. We are on a completely different scale, and I don't mean we're in the good direction. Right. Anyway, with that cautionary note, I'd like, first of all, to open it up to you guys sitting there to ask questions of these guys sitting here. And if you keep talking, it means I won't have to. Alan.
Thanks. I'm happy to start, and thank you very much, everybody. I would like to put a question to the Sightsavers and DNDi, because one thing I struggle with is how much money should we spend to raise money? And what sort of balance is acceptable in your view, and also perhaps in the view of the donors? You know, do you spend 10 million to raise 20? Or do you spend 10 to raise 100? What sort of percentage are you willing to spend, and how much are you hoping to raise with it?
Do you want to go first, Michele?
Thank you for your question. So in terms of what's a good ratio between monies raised and monies spent, in all of my experience, so not just with DNDi, and in Canada as well, a good ratio is if you go beyond 25%, donors start to ask questions. So if you can keep your costs under 25%, that's brilliant. Now, to raise money, you need to invest money. And just like any business, you might have some high upfront costs. So you may have to hire a fundraiser who will only start being productive within 18, 24 months. So what I did when I started the program at Médecins Sans Frontières is I had a 5-year rolling average of what my percentage was, so that I could, you know, kind of show that 25%. And in fact, when we had a natural disaster, my ratios were really, really great, because it cost us no money to raise money, or very little, just the amount to send out the receipts and a letter of acknowledgement. But if you can do that, and one way of positioning it is kind of showing a 5-year average, so that those startup years where you're investing in promotional material, meeting donors. If you're looking at a major gift program, which is what we're doing at DNDi, it takes on average a good 18 months between the time that you may meet a donor until you secure that first gift. And that's really fast. I've done some of it faster, but some of them it took me 5 years. So, and lots of visits and lots of tea.
Thank you. Tobin.
Yeah, I think there's lots of good advice there. I mean, the only thing I would add is that I mean, I think there's a huge amount of misconception and misunderstanding about fundraising costs, and you know, what's a good figure, what's a bad figure, how do you show how do you show it? I think the answer for your organisation will be different to other organisations, because your fundraising mix will be different, what you're raising money for, how you operate, that will be different. The really important thing is net income. Now, you know, I think it's responsibility of all fundraisers to generate as much net income for their organisation as possible. I think then you need to explain to your donors what that means in terms of fundraising ratios. But there's lots of ways to do that. I think getting fixated on a particular figure is something to be avoided at all costs.
Okay, so it's a good question, but it's actually got two answers. One is about percentage, and the other is about the timing. And put that in perspective, I used to work in a regional university in the UK, and about 10 years ago when I talked to our equipment office, they were delighted. They were one of only 6 in the entire UK that actually got in more money than they spent on their own salaries. I hope that is horribly out of date. Right, right. Thanks, Al. Yes. So we're asking people to use the microphones because that way we can capture the conversation.
Jutta Reinhardt from Merck Serono. If I may give you a kind of provocative statement, I think the success of the MDA programs are the enemy of R&D. For especially, I'm talking about schistosomiasis. We have praziquantel, and within my company, we have a big program on donation of praziquantel. But it's really, it's the success and the data we see when we apply for R&D funds, even in the company or from other organizations. This same question comes, but you have praziquantel. It's a successful drug, it's safe, it's efficacious, and it kills a lot of R&D efforts, where you could have, as a scientist, you can have many arguments why you need additional drugs in the pipeline. So it's a bit for discussion how this is maybe in other diseases. But I can only share DND Eye's observation. It's very difficult to get funding for R&D.
I think that's a very good point, that there is this tension. I would actually generalize the point, if I may. There's also a tension between control programs and eradication programs, and that it's something, there is no single strategy that works. A strategy that works incredibly well for soil-transmitted helminths and integrated control now would not work if you were down below 1% very well, and I'm glad you're shaking an agreement, Neeraj. So there are a complex mix of strategies that's required depending where you are on that pipeline through to better control and hopefully elimination and eradication. But I think your point's well. Is there anyone in particular on the panel you wanted to respond to that? Okay. Okay.
Just to make a comment on that, because I do think it's true, and it comes into the complexity of our message, and I think that the selling of success and that this can work then needs to be nested with and work in partnership with our research partners who are then saying, we can do all of this, we still need some more tools. You know, because once you get further down, like diagnostics is one of the areas where I think we're very behind in the NTD space, is that, you know, we have great tools or sufficient tools, great is really an overstatement, to start programs, but not enough to monitor and to be able to say we actually hit the target. And so I think integrating in those messages, or bringing in, not to use integrate too much, bringing in those messages at the right time, and it's when do you bring those in? Because I do think there's different donors that are interested in that piece. Some, it's all about, you know, we know what to do, we can do it. And then others, it's like, there's risks, and how do we mitigate those, and bringing in the research to be able to do that.
Nice points. Other points? Yeah.
Hello, my name's John Snellgrove. I'm an optician and inventor of a new type of spectacle frame solution. I've got a question about public-private relationships, in that do you have any experience whereby you sell a solution to the public sector, from the private sector, make a profit, and then return and cycle those profits back in to the system to grow your organisation? Has anyone got any experience of that?
Want to have a go?
Sorry, not to hog the mic. So we've had different experiences with those, and I'm going to reflect on my experience from PATH, when I was at PATH, which is a nonprofit working in Seattle, and then for the foundation, and just awareness of other programs. So there's some really interesting stuff that's happened in Thailand with around condoms and having a whole group of different for-profit pieces that then support AIDS prevention, providing condoms and education and different things going into the nonprofit sector. Very creative, very interesting work. So on the other side, there's a lot of things that are smaller industry-related pieces of selling, so that you have a for-profit end to the solution, working with the bottom billion in a for-profit way. One of the challenges coming from having been at PATH is one of the products that PATH developed was called the Uniject. So it's this little teeny tiny plastic ball with a needle. So instead of having a needle and a syringe, you have this little fill plant. So you could take these and you could peptide C, you could put in tetanus, you could put in drugs for stopping postpartum hemorrhage, and give them to traditional birth midwives and have them take it to the home, immunize the baby, related to anything went into the non-restricted funds for continuing innovation, which was a great idea, but actually when it came to advocating the word using UNIFEF and getting it out there, practicing is being conflicted. And so in the end, they had to take and look at that royalty and then drop that royalty, because when they were talking to UNICEF, they weren't allowed to be at the table to talk about the potential applications. So there's very interesting, delicate lines to those pieces and how you do it, but there's many different models.
You might think from the Wellcome Trust I might be able to answer that question, and I can't, simply because we're a charity. We are a gap funder on anything industrial. So anything where we perceive there might well be a profit margin, we have to deliberately walk away from, or we're starting to run into difficulties with the Charity Commission, is my understanding. I'm not actually involved in that side of it directly. But I think your point is an interesting one. It's a sort of, it's a curious angle that a number of speakers have mentioned this. There's a plurality of funding, but often some of the best things are when multiple funders get together, multiple donors get together. And here we've got something where there's a genuine disjunction, where you'd actually think it ought to be the easiest bit to work. Thank you.
It just appeared to me that from a commercial perspective, coming in sideways, which is where I'm coming from, that the governments that need the services and the systems don't have them in place. And then when the sort of buy one, donate one concept kicks in, that then the government gets the resources and the funds and the products and the systems all in one go. And then the return comes back to the provider to expand that idea. So, for example, in my idea, I'm looking at using it on the spectacle frame market on a buy one, donate one basis, and then the 200 million people hopefully will get free spectacles. Thank you.
Thank you. Oh, sorry.
DNDi is very interesting. We have about 100 partners that we work with in the private sector, academia, contract research organizations. The diseases that we chose to work on are really, there is no market, unfortunately. To ensure, so we have some new treatments that have been developed. To ensure that they continue to be produced, we actually accept that a very minimal profit can be made on the treatment. Might be even maybe 1%. That goes back to the pharmaceutical company so that they continue to maintain the production of that treatment. But we made a choice of not making any profits on the treatments that we develop.
Okay. Hi, at the back, and then we'll come to you. Was it the back first?
Hello, Gabriel Müller, my name from Light for the World in Austria. I just wanted to reflect on the shark and the goldfish, because I know these discussions, especially when I'm going to Switzerland, but they have a very clear understanding of who is what. I'm not sure whether you're really the goldfish, because the NGOs, often we are engaged in trachoma, in sub-Saharan Africa, etc. The NGOs are taking the first risk in building their relationships on the ground, in investing in people, capacity building, advocacy, and everything, taking the risk, taking the money, and then hoping to get the funding for it. And many of us are investing much more money in effective work on the ground, on the field, than many, except of you, of course, foundations with even bigger names. And but the feeling, and this is somehow contradictionary, is we are the sharks looking for the money, but we have done the promises in advance.
Your point is well taken. It's very context dependent. Yes, yes. Right. I think there was a question here. Sorry, and there. So perhaps. Right. Thank you.
Hello, my name is Remco de Vru. I'm with Top Institute Pharma. I'm fairly new in the field of neglected diseases, but I have been involved for quite a number of years in the field of rare diseases, in which venture philanthropy is very active, and it's part of where the growth is what I understand as well. we did some research on that. What is the role of venture philanthropy in that area? And one of the things that came out of that study is that they are not in it just for giving the money. They really want to build up a partnership. So my question is, how do funders within the area of neglected diseases view themselves? Do they view themselves as being a funder, or do they also contribute in other areas, like, for instance, clinical trial sites, screening libraries, compound libraries, things like that? So maybe, I think there are 4 funders in the room, so maybe they can comment on that.
Joao, would you like to speak first on that?
Yes. Let's just say something before, because I think that a lot of goldfishes make a big shark. So, and for example, in Calouste Gulbenkian Foundation, one of our major partners are on NGOs on the field. I don't know if you noticed, but we are working, when we do health research, we didn't start with health research. We started with effectiveness studies in the field, with NGOs implementing those studies, and we connected the NGOs with the universities in Europe to get them the protocol, the clinical protocols, the studies, how they can collect data with a scientific view, not with the humanitarian view. So we are trying to connect NGOs and universities, and this is the way we are working in the last 3 years, 4 years, and it's giving results. So we are effective partners because we are connecting NGOs and universities, because universities like the suits, NGOs like the short pants. So we are trying to do in the middle this connection between these both partners being a partner. I have no problems with the pharmaceutical industry working with us. We work in the past. We are working with Praziquantel in Angola. We are not trying to develop new drugs because clinical trials in Africa are sensitive issue, and we are working epidemiological studies, but we are trying to focus on the drugs already existing and the way they are effectiveness in the field, because Praziquantel works, but for, I don't know why, sometimes doesn't work as so good as it has to work, mainly in children, mainly in different populations. So that's why we started with epidemiological, NGOs, started to grow to universities, and trying to grow to clinical partners. So yes, we are funders because we have the power and we have the ability to have risks associated. I would not be fired at the end of the year if I don't give money or I don't receive money. So I have no axes in my head if I don't do my job, because my job is to be present, to get people together, and do something effective in the field. So we are a partner.
Thank you. Can I come and work for your organization? Because if I did that, I would get fired. Right. Perhaps Julie, you'd like to come in as well.
Thanks. I was thinking the same thing. So yeah. So I think that one of the pieces is looking at, and I think this reflects on your question, but also on the comment about the goldfish and the sharks analogy. It comes into assets, right? And what are the assets that we have on the table as partners? If we truly look at ourselves as being partners in this space, you know, it's not just dollars, right? And I think the Gates Foundation, I think, you know, definitely Bill and Melinda would like to see themselves as thought partners within the problem solving, you know, so as far as the assets that we're putting on the table. Working with pharma, the compound libraries, absolutely. And reflecting on the London Declaration, the initial commitments that were made with the London Declaration on NTDs, there was compound library pieces, and there was donation, and there was support for some of the implementation components. But that's expanded in the interest of pharma to participate in this and to see themselves now not just as putting, you know, we put the drug out and then you guys make it work, but seeing that we're committed to these goals, not, you know, not to giving out so many tablets, but to these goals. They're continuously looking at what can we do more, what other assets do we have. And supply chain, we are engaging DHL, and we actually, it's really the pharmaceutical industry who's engaging DHL to streamline all of those pieces to come together as partners so that if we want integrated programs, the drugs have to arrive there at the same time. And programs can't work that way, and so by working together, they can help the programs be more integrated. So I think there's a lot of ways if we change our perspective from just individual donors or putting one thing to being partners. And on the NGO piece, the assets that the NGOs have are irreplaceable because you have relationships and you have trust. And if you don't have either of those things, you do not have a program. You know, so don't underestimate the power of that piece and that asset that is irreplaceable. So I think all of those things together need to be part of our perspective.
I think you also raise a very interesting point is, you know, where can we learn? What are the sectors? And I think rare cancers is a sector where we can, all of us, learn a great deal, because a lot of the issues that we deal with have actually been dealt with, but in a first world context by people who are trying to do similar things on rare cancers. Uppermost in my mind at the moment is Ebola. We're trying to think, we're going to have a phase 1 trial finished by Christmas. We move to phase 2. How do we design that trial? Actually, we'll probably use an oncology-based model because it'll work, whereas the traditional infectious disease models probably won't work for an Ebola context. So I think that's a nice point. Sorry, you've been very patient.
Hello, good morning. My name's Gail Glover. I work for LEPRA. I'm a corporate and major donor fundraiser. This is a brand new strategy for LEPRA, despite the fact we've been around for 90 years. We've really not fundraised from the private sector in the past. I was interested in something that Dr. Mistry said about how it's very useful if you can get senior executives, you know, from corporates to talk about what you do. So do you think, as a general strategy, to try and get the attention of philanthropists, that organizations like us, like LEPRA NGOs, that we should be looking to try and recruit corporate ambassadors to sort of talk on our behalf?
A few ways of actually doing this. One of those is to actually get, in some parts it's called a speakers bureau, and so it could be advocates, former presidents, or prominent people in society that could speak on behalf of the cause. But I think developing an institutional relationship with a corporation is actually the way to go. And it's generally knowing someone at a high-level position within the corporation, and everything from getting a board member from a corporation to doing employee engagement programs and doing fundraising in that way during the holidays or Easter or that sort of thing. And it's amazing how people in the corporate sector are actually looking to engage in these sorts of social issues. So I would say the key thing is to actually develop that sort of institutional relationship and then figure out what you can do together. But what I've found in my experience is it's finding a champion or having a relationship with someone from that corporation that opens the door and begins that discussion.
Thank you.
I just wanted to expand a little bit on that and offer a small but very optimistic comment, and perhaps echo something that came out of our meeting on water and sanitation for public health earlier this year. And we had actually quite a lot of private sector attending and involved there. And for example, Greg Koch, who's head of water stewardship for Coca-Cola, was explaining that along their supply chain, they have possibly thousands of small programs. There's a great desire by the private sector to actually come on board, and perhaps where the water sector has a slight advantage is that it's been perhaps more intuitive for the private sector to engage. You know, Analia Mendes from Unilever was asked, okay, well, if, you know, we want to partner with you, what should we do? And she said, well, just pick up the phone and phone me. I'm sure it's not always that simple, but the relationship is there, and the willingness is there. And I think with all this fantastic case that we've heard this morning for NTDs as a sector and as somewhere where all sorts of private firms can come, whether they have a diagnostic tool or whether it's DHL. So I think it's a kind of an inflection point for NTDs, and we're going to see a lot more of these partnerships coming up. Just an encouraging comment there.
Thanks. Tobin, I wonder if you said specifically this is an area you're actively exploring. I wonder if you wanted to sort of come in with an extra comment on that.
Yeah, I mean, there's a couple of things that strike me as quite interesting about about this. I mean, clearly, NGOs need to make themselves relevant to business, and I don't think we're always that brilliant about doing that. But even when we have established relevance, we don't sometimes seem to exploit that. So I think, you know, pharma companies and the NTD space is really interesting. You've got these enormous drug donations going out. These are some of the biggest philanthropic donations by companies in the world. But how many pharma companies have actually got relationships with NGOs working in this space? Real relationships that aren't just thanks for the drugs, guys. Really, not very many. So why haven't we made that work? You know, well, there's lots of potential reasons, but I think it all comes back to the word that's been used quite a few times here: relationships. You know, find out who the people are. You know, build trust and engagement with them, and go from there.
Thanks. Okay, thanks.
Thanks. I'm Zoe from the Leprosy Mission. I was really encouraged to hear what Tobin was saying about your increase in income, and actually that some of the funding for NTDs is coming in, which is obviously sometimes a difficult, but certainly a difficulty for us. So I'd just be really interested to know, is that institutional funding, is it foundations, or is it your individual donors doing that transactional type giving?
Well, it's now a mixture of them. I mean, the sort of up to sort of 2 or 3 years ago, this was very largely institutional, and specifically DFID actually, you know, DFID have really engaged in this NTD space. It has significantly increased funding opportunities, and that money is starting to come through. And some of the other funders we've had have, that's been, you know, related to that. So the Queen Elizabeth Diamond Jubilee Trust and their very large trachoma program they're funding, for instance. But we are now seeing increases in other areas, but that's because of a strategy to develop our fundraising. I mean, you know, it's actually about you know, things we haven't done in the past and we are doing now. So I think a lot of fundraising is very much within the control of your organisation, and it's about having good strategy, having the right goals, uniting the organisation behind it.
Thanks. Michele, would you like to come in? Because this sort of alludes to something you specifically said. You've actually got an objective to set up a particular proportion of funds coming from different sectors.
I won't deny that raising private money is a challenge. It really is difficult. When I was at the university and I had to raise money for oncology, I could go into a database and just put in oncology, and I would get, you know, hundreds of foundations and individuals and high net worth individuals, corporations that would be interested in supporting oncology. But when I came to DNDi and I put sleeping sickness, nothing came up. When I put leishmaniasis, it didn't accept the word. So we were really starting from far behind. But you know, that being said, there are you've got to come up with a creative way of repositioning what we're trying to do. So some of the key words that I decided to use was poverty, Africa, Asia, Latin America. So a combination of words drew some names, some foundations. We have terrific relationships with the Gates Foundation, with other foundations in the US, and even now we're building them in Brazil, and I'm using them. You know, it's not just turning and saying, oh, would you consider supporting this project, and that's it. Can we take it a step forward? Do you know anybody that we could approach? Could you open that door for us? Could we go together? And we've got a great example that we're going to be putting in place in New York in a couple of weeks from now, where one of our donors that's been supporting us for the past 5 years has agreed to kind of be on the invitation list. They've got a big name in New York. We're hoping that it'll draw other people and position DNDi where we ought to be positioned, because we have delivered 6 new treatments since 2003. So yeah, in terms of other relationships that we develop with industry, Julie mentioned, screening. We actually we're building what we call a drug discovery booster. So essentially, it's this group of people at DNDi. We're approaching several pharmaceutical companies and accessing their compound libraries. Our goal is to attract 11 pharmaceutical companies from around the world, from Japan, from Europe, from North America, to see if we can fast track, so use their compound libraries. Not only that, but also their knowledge, their chemists, their staff, to helping us. And they're anteing up. They're coming to the plate and helping us, which is terrific.
Thank you. It's a question sort of halfway back, and then... Sorry. Yes.
So this is both a comment and a question. I'm Karen Moshal. I'm an infectious disease consultant across the road at Great Ormond Street. So I'm a bit different to a lot of people. I also have an NGO hat. It's very exciting to hear the people starting to think a bit more creatively, but what people have alluded to but not addressed directly is donation of skills and donation in kind. We ask doctors, nurses, etc., to donate their time to go out and into the field, but actually, surely we should be doing that of big corporates and people with other skills that we don't traditionally associate with the aid world, such as people who are systems experts, people who are financial experts, who can teach development people in the field how to negotiate lower prices, for example, for drugs, how to set up robust systems for delivery of drugs, etc., which, as medics, we are not the natural resources for those. So perhaps somebody would like to talk about that. It's also a need to get money rather than asking for money.
Neeraj, could you?
So there's actually some really good examples of those sorts of programs, and I think it was identified by a pharmaceutical company that this was the gap. There were no HR people and accountants and that sort of thing. So Pfizer developed this program called the Global Fellows Program, where they would deploy, while paying the salary of their staffers, for 6 months to a year and a half, people to the field with competencies outside of medicine and research to actually assist organizations build their capacity. In my previous organization, we had a Pfizer fellow come. So that's quite interesting to look at. The other model is also Accenture Development Partnerships, which is specifically bringing the competencies of the consulting world into the development context. And there's a whole different rating system that they use. One anecdote I'll point from the Pfizer program is, while all these fellows, and I met quite a few of them and spoke to the head of the program, while all of them went out to teach, they often say they learned more than they taught. So I think it's a bi-directional process, and it's really helpful to bridge the north-south divide.
Thank you. That's a very nice point. I'm conscious of time, so I'll focus. Julie, do you want to have a coffee on time or not? Right, okay. I'm delighted you said that, because Lady in Red has been very patient.
Thank you very much. My name is Francisca. I'm coming from the NGO sector that is involved in river blindness in Nigeria and other NTDs. I have a question, and the question is on access, to be able to reach these communities that are really burdened with these diseases. Sometimes they are cut off because there's no bridge to kind of cross in, or they live on top of the mountain, no helicopters to get there. So I'm just wondering if there's a group beginning to look at, because if we don't get to them, we can't get these medications to them, and they remain a reservoir and at risk for people that are even taking the drug. So I'm just wondering if we are thinking in that direction, or is something that we'll begin to look around to see who can do that for these communities. Access, and sometimes just a bridge to be able to get them. Thank you.
Absolutely. All boils down to logistics. Yeah. Joao, do you want to have a go at that?
Yes. As stated on the presentation, we are working in a health research center in Angola. And the major participation is not from European philanthropy, is not from European parties, is from Angolans. And one of the major parts we are working with the Angolan government is roads and access to the hospitals. So our work didn't start until 2007 with the research center, but with the hospital and the roads and the Chinese ministry, because they were working on the roads. So we cannot work with the population if the populations cannot reach the hospitals or vice versa. But one minute, a comment and a provocation. We are discussing global health, but we are not discussing global philanthropy, because we are discussing European philanthropy, American philanthropy, but we are forgetting a player that is rising. It's African philanthropy and Asian philanthropy. In Angola, we are working with a foundation, Angola Foundation. Yes, it's a foundation of the president, but it's an Angolan Philanthropy Association, and they are financing our projects. So there's another donor around in Africa. So, and it's very difficult, and I have to say for our own experience, when we have problems in our doorsteps, because Portugal is facing some economic crisis and the health sector is gaining some problems, it's very difficult to sell and buy projects in Africa when I have so many projects to buy and sell in Portugal. So we have a diminishing our money available to Africa projects and Asia projects, and we have a rise in Portuguese projects because we have this problem. But we can face this gap with African philanthropy and European private sector working in Africa, because Angola have a strong law about social responsibility. So we have receiving money from companies that they have to give money to social investment projects in their own in the countries where they are working. So one small